Thank you, Erin. I'm Martha Bergren, and I'm here to talk about a study that was conducted through the Albert Shanker Institute here at the AFT, within AFT. And I'm just going to give you a little bit of background before I get into the specifics of the study. So Erin has described why school nurses in schools to provide health care. And we know that the 74% of all United States schools that have school nurses in them have unprecedented access to children who can be uninsured, underinsured, and undocumented. School nurses are where the kids are at school every day. We fulfill the mission of public health. Public health depends on schools and school nurses to make sure that children have immunizations upon school entry, surveillance of infectious disease, and many other aspects of the public health mission. And as Erin has discussed, we're very involved in the care coordination for chronic health conditions in schools. So we know that school nurses are a highly educated workforce. So 50% have a bachelor's degree and another 28% have a master's degree. So not only are the school nurses highly educated, but they're also incredibly cost effective. School nurses are the least expensive of all nursing specialties, but are the most satisfied of all nursing specialties. So as you can see, a nurse who works in a school can be an excellent bargain. But the problem is that many do not understand what school nurses do. They think that they remember what school nurses did when they were in school, and the conditions in schools have changed significantly since the passage of the Individuals with Disabilities Act, where all children, no matter what their health is, can attend school every day. So we also don't know, as well as Terry can describe, the impact of school-based health centers on the health and education of children. Because school nurses do not bill for their services, we don't have the type of data that school-based health centers do about the care that's provided by school nursing. So we had a dilemma. We wanted to be able to describe what school nurses do and what the impact on health and education outcomes were. But there's actually a dearth of data on school health care. Many school nurses do not use electronic health records in schools, and there's the use of multiple unlicensed personnel in schools. So if we cut school nurses, what will be missed? We weren't able to answer that question definitively. So the advisory committee at AFT, the School Nurse Advisory Committee, was perplexed by this dilemma and wanted to look into funding to describe how school nurses made a difference. But we needed to find out how feasible is it for school nurses to collect the type of data that's needed in order to make those arguments. We knew that there had been instances across the United States where school nurses had been asked to collect comprehensive data when layoffs were looming, and yet they were not able to do so. They were not able to collect voluminous data on top of the role that they were playing every day. So the advisory committee felt that to be palatable, to be doable, feasible, that the number of data points that the school nurses were asked to collect had to be limited. Not everything under the sun. We were going to collect a limited number of data points on what we felt was important, and hopefully easy to measure, and ideally already documented. So we put together a study that very thankfully was funded by the Albert Shanker Institute to measure how feasible it was to collect school nurse-generated data. So from a list of 57 identified measures that had been identified by the National Association of School Nurses leadership, we selected data that was sensitive to school nursing quality and intensity, meaning how large of a student workload did the school nurse serve, for instance, Massachusetts compared to Utah, and was it important to our stakeholders? So not just important to school nurses, but important to the public and important to education. So from that set of 57 indicators, the School Nurse Advisory Committee here at AFT identified 4 four indicators that this study was going to measure. We felt that it was important that the number of health office visits be measured. Erin mentioned early dismissal, whether or not the school nurse sent students home from school or they were able to return to class. The number of medications that were administered, we felt that that was a significant data point. And because of the emphasis on care coordination within the Affordable Care Act and the importance of it to accountable care organizations, the communication that the nurse provides between the parents, the staff, and the healthcare provider was also measured. There were a few data points that were considered but were not selected, and that was the immunization rate, whether or not students were excluded from school due to lack of immunizations or physical exams, the number of medication errors, and school attendance for a variety of reasons. We had to limit it, and these were the four that were selected. So instead of collecting data over an extended period of time, we collected data across a 5-day snapshot, and 15 questions were asked each of the 5 days of the data collection. On the first day, there were also 14 demographic questions that were asked. And within a pilot, we estimated that this would take about 15 minutes each day for a school nurse to respond to. This is just a sample of the web interface that the school nurses filled out each day. And we found that we had solicited participants from the National Association of School Nurses who were also AFT members. And we had 42 nurses respond who, on initial review, were deemed to be eligible for the study. However, we found out that some of those 42 were ineligible, and by day 5, 31 were still part of the study. The data collection time decreased daily, each day. There were some outliers on the first day. Even though most could complete the web interface between 5 and 15 minutes, we did have some that it took 40 minutes to complete. But by day 5, the time to complete the survey was 6.6 minutes, which pretty negligible when you think about the length of the day and the amount of data. As you can see, the number of respondents did decrease each day, and you know, that really does tell us that data collection can be difficult for some school nurses. The average caseload within the study was 996 nurses. We know that the average school nurse serves
Students?
The average caseload was 996 students. And we know that the average school nurse serves 1,051 students, so comparable to the average school nurse. But there was a very wide caseload range, 47 to 4,500 students. And the number of schools that were served ranged between 1 and 6 schools, with the average number of schools served 1.66, which again is similar to what we know is the average in the U.S., which is about 2.1. And within this study, 92% of the respondents had a bachelor's degree or above. So across the 5 days, those school nurses had over 7,000 health office visits, administered over 2,200 medications, and well over 1,500 communications. And I have it broken down here: parents, health providers, and staff. So on an average day within this study, a school nurse saw 43.5 students, or 6.5 students per hour. Significant amount of health care going on in school. 14 medications were administered daily and 17 communications, so care coordination going on between parents, staff, and healthcare providers. So what was also remarkable is across the 5-day period, 59 unique medications were given by this small number of school nurses. And for those of you who recognize some of these drugs, they are incredibly powerful psychotropic type medications, which really did catch us by surprise, the range of medication that was given by such a small number of school nurses. We were able to add each day to a drop-down menu so that new drugs did not have to be entered by hand each day. So now we have a nice drop-down menu should this study ever be replicated. So one of the findings that we had were some of the qualitative comments that the nurses made that I have to say were not expected. How much they enjoyed doing it, how it validated their worth within the school, and at the end of the day, sometimes when you've just been so busy, it felt good to see that concretely what actually you had accomplished that day. And that it's easier than we thought. I can't wait to see the results, and just pride in their accomplishments and in their work. There were some limitations with the study, and it's one that we've actually been finding in some other studies that we're doing, and that is some of the what the nurses call guesstimates. So some admitted that the communications with parents, staff, and healthcare providers were not recorded. They had not recorded those in their nurses' notes. And this is significant when we are trying to advocate for the amount of care coordination that goes on in schools each day. It's essential that those communications with the parents, staff, and healthcare providers be documented. The nurses did comment, and I could tell, because I could see when they were filling out the data, that some of the data entry occurred several days after the care was actually administered, which again raises concerns about the reliability of the data. And then also some of the round numbers that were used led one to question whether or not those were also estimates and inaccurate. We did note that it was much easier for school nurses who had electronic health records to collect and submit this data. And that some of the implications are that it is difficult for school nurses with their responsibilities to sustain the data collection over a long period of time. Some could not sustain it more than 2 to 3 days. And there are places where some of this data can be looked up easily, and we felt that perhaps some school nurses did not know how easy it was to look up, for instance, how many school nurses a particular school served. This is all available on the web. But we did find that nurses were validated by this process, and that when you collect just a few salient items, that the data collection can be feasible. And it is of concern the number and complexity of the medications that are administered, when we know that in states like Utah and other states that unlicensed personnel are administering fairly potent medications on a regular basis. So we want to decrease that data collection burden, accelerate the adoption of electronic health records, and the adoption of a core data set in order to make data collection more feasible and easier for school nurses. So, thank you. I'll pass this on to Tom.